Electrical storm is a life-threatening cardiac emergency characterized by recurrent ventricular tachycardia or ventricular fibrillation. By definition, 3 or more episodes separated by more than 5 minutes within a period of 24 hours characterized an electrical storm. Data on electrical storms are mainly available from those with implantable cardioverter defibrillators, as there is an accurate documentation of the event in the device memory. While an occurrence of 4% over 20 months has been noted in a primary prophylaxis situation, 20% over 30 months has been reported in those with an ICD implanted for secondary prophylaxis. Similarly, 1 year survival in electrical storm is also highly variable, with reports ranging from 5% to 35%. Mortality following an electrical storm is often due to progressive heart failure. It is not clear whether this is due to the occurrence of electrical storm in those who are very sick, or the myocardial damage due to multiple shocks cause progressive heart failure. Beta blocker is the single most effective therapy for recurrent VT unless the person is in shock. A combination of intravenous amiodarone with oral propranolol has been found to be superior to intravenous amiodarone with oral metoprolol. Stellate ganglion block or ablation is being increasingly used as a modality for treatment of drug-refractory ventricular tachycardia. Temporary blockage of stellate ganglion can be obtained by injection of lignocaine or bupivacaine for a longer effect. Sometimes a cannula can be left in situ and a local anesthetic infusion started for prolonged effect. Ablation of stellate ganglion chemically with alcohol or surgically are feasible. Video-assisted thoracoscopic surgery is a semi-invasive option which is replacing open surgery for surgical ablation of stellate ganglion. There should be a low threshold for inserting intra-aortic balloon pump in those with electrical storm. ECMO support is useful in pediatric cases as hemodynamic protection for aggressive anti-arrhythmic medical treatment, giving a survival of more than 80%. Moderate therapeutic hypothermia has been shown to suppress electrical storms in a person with multivessel coronary artery disease. The converse is that patients with fever may have worsening of electrical storms, so the control of fever may be useful. Monomorphic ventricular premature complexes which trigger the ventricular fibrillation should be targeted during ablation of VF. The best time to take them up for EP study is during a storm, as the tachycardia may not be inducible at other times. Marking electrode positions while taking ECG will help pace mapping at EP study to get an exact match. Excellent outcomes for catheter ablation with resolution of storm in over 90% of patients and a complication rate as low as 2% has been mentioned.